Thanks for coming out. I was asked to give this talk about diabetes, and I was asked to talk for about half an hour, 40 minutes, and answer some questions after. And I'd be happy and delighted to answer all your questions throughout the whole thing. We don't have to wait till the end. And if there's any questions in between, after a slide or anything of that nature, please let me know. Just raise your hand or whatnot, and I'd be happy to discuss anything. And please make this informal talk, so please, at any time, if there's anything you don't understand or anything you want to add to the discussion, please do so. And so right away, if anybody wants to add that today's actually not July 25th, today's actually July 23rd. I made this presentation up a few weeks ago, and apparently I didn't realize what date it is. So that is the first order of business. This is actually July 23rd. So what is diabetes? Who has it? And why should you care about it if you do have it? Or if you know somebody who may have it. So the definition is basically diabetes is characterized by diabetes mellitus is characterized by high glucose levels in the blood. And why does this occur? Anybody want to give a possibility of why? No pressure, but if anybody has any guesses or any ideas why they think it might occur, please feel free. Great answer. So that really answers at a molecular level that it's it sometimes gets passed down from your parents or from your grandparents or from other people in your family. But I was sort of thinking more physiologically, why do you have high blood sugars in your body? Sure, exactly. So it's tied to weight. Absolutely. Diabetes is tied to weight, and I'm going to show you some nice slides on that. There's two major reasons why you might get high blood sugars, essentially. It's if you don't have enough insulin in your body, meaning you're creating an insufficient amount of insulin, or if the insulin is ineffective, or in what we're going to talk about, insulin resistance, meaning you're producing insulin, but the insulin your body's making isn't working as efficiently or as effectively as it should be. And that's typically why you get high blood sugars, because glucose and insulin are going to be working in balance to keep your energy requirements in your organs and your cells working efficiently and properly. And what is insulin? It's a hormone that brings, essentially, as simply as we can say, is a hormone that brings glucose or sugar to the cells and organs of the body. And glucose is the fuel that drives the body. It's the fuel that drives your muscles, your heart, your brain, all the organs and cells in your body. And anybody know where insulin is made or released from? Exactly. You guys know it you're way ahead. And so here's the pancreas right here. As you can see, this is a nice little depiction right here. The pancreas sits right here, and it's if I can draw a line right over here. When you eat, you swallow food. I don't know if it's coming here. I don't know if it's coming too good there. All right. Anyways. As you can see, there we go. There's from right here, you eat food and it comes down your esophagus, and then when it comes through your esophagus, it goes through your stomach, which lies right here. And your pancreas right there, in response to a stimulation of glucose, will release insulin as it works its way through the intestines, and then your insulin goes up eventually and then comes down. And this is a little depiction of how insulin is thought of. It's thought of as the key to unlock the entry of glucose into the cell. And when do you need insulin? And I gave you a little bit of a hint. You need it 2 times of the day. It's a little bit of a trick question. So I kind of gave you one of them. So you need it certainly when you eat. How about the rest of the time of the day? So when you're eating, you need insulin, and when you're not eating. So it's sort of a trick question. You need it throughout the whole day. I mean, all day, all times of the day. And how do we know that? It's because what happens in the middle of the night when you're not eating? A lot of people with diabetes will come into our office and say, you know what, I ate my dinner. My sugars were great at 11 o'clock at night or 10 o'clock at night, 9 o'clock. I checked it. They were perfect. They were 95 or something like that. And then I woke up in the morning, and they're 200. And why is that? And it's simply put because your body still needs energy and it still needs glucose even when you're sleeping, when you're not eating, when you're in the fasting state. And it does so by making glucose through the liver. The liver has lots of storage of glucose, and it breaks down some of its storage and produces glucose into the bloodstream. By doing so, in diabetes, a lot of times that signal of creating insulin when your liver is making glucose, when you're not eating, is disrupted, and it's not working effectively or efficiently. And it doesn't turn off that signal, and it can't keep up with the glucose production. So everybody has some idea, or a lot of people have some idea that you need insulin when you're after a meal. But it's not always clear to everybody that you need insulin also when you're not eating, because, as I said before, your glucose levels at night don't go to zero. Even if you don't have diabetes, your glucose levels don't go to zero, and they don't go to 500 or 600 either. They sort of stay in this even keel, and that's the balance between glucose and insulin during the middle of the night. And so there's two major types of diabetes. Major types. There's a lot of different other types, and they're usually a little more rare or genetic. But the ones I'm going to talk about this evening is type 1 diabetes and type 2 diabetes. And does anybody have an idea of what the difference between the two are? Exactly. So that's the way it was sort of came up about. So juvenile. What does that mean to be juvenile diabetic? Sure. So juvenile certainly means young adults and things like that. But what characterizes their diabetes besides being young? Is it only? Yeah. So I heard the right answer. It's an autoimmune function. Explain what that means if you don't mind. Or do you know what that means?
Your body makes an antibody against your own insulin, or it destroys the pancreas so that it becomes non-functional.
Exactly. Right on the button. So I don't know if everybody heard that, but it's an autoimmune condition, and that's what we sort of classify type 1 diabetes as. And autoimmune means that your body's working against itself. And how does it work against itself? As we heard here, it's an antibody in your blood, and an antibody is a protein that provides your immune system. You know, it fights your infections, fights your colds, does a host of other things for your defense system. Well, in autoimmune conditions like type 1 diabetes, like some thyroid conditions, like some lupus, like rheumatoid arthritis, they all have antibodies that will, instead of working for you, works against you. And so in type 1 diabetes, these antibodies will attack your pancreas and the cells inside your pancreas and actually disrupt the insulin-producing cells. So therefore, you don't produce enough insulin. And in fact, you're producing very little insulin at all. And so that's what type 1 diabetes. And so what we heard back before is juvenile diabetics is that we used to think that that's what we used to classify it as basically most kids who are very thin and get very sick with nausea, vomiting, and all sorts of other sicknesses, and they get diagnosed with diabetes, they're typically a type 1 diabetic where they're not producing essentially any insulin or very, very, very minimal amounts of insulin. That's what characterized by type 1. The reason why we don't say juvenile diabetics, anybody have an idea? Yeah, exactly. We found out that it's not only related to adults. It can affect, it's not only related to children and young adults. It can affect, there's reports of, people well into their adulthood that have developed diabetes. So we sort of went away from the juvenile diabetes because that doesn't encompass everybody. So then if we have juvenile diabetes, type 1 diabetes, we have type 2 diabetes. And we heard a little bit of a characteristic of a type 2 diabetic. Anybody else want to classify what type 2 diabetes is? Exactly. So obviously, if you have a juvenile diabetes, then you have to have an adult diabetes, right? I mean, there's the natural opposite. And as we found out is that it's not just adults who get type 2 diabetes. And type 2 diabetes is really characterized by not only an insufficient insulin, and when I say insufficient, I mean they're producing insulin. It's not like the type 1 diabetics. The type 1 diabetics aren't producing insulin. The type 2 diabetics, they're producing insulin, but their body is resisting insulin in a big way. And so they're not able to keep up with that regimen. And so some of the things that you might see is sort of what we just mentioned. So they don't make any insulin, and they need insulin almost essentially from the time of diagnosis. So when you hear somebody who was 4 years old or 3 years old or 7 years old, they had type 1 diabetes. They're usually younger, as I mentioned. It used to be juvenile, and oddly enough, even though it's an autoimmune phenomenon, it tends not to have a family history. Only about 2 to 8% of people have a parent who's affected with type 1 diabetes. And if you have identical twins, only half of the people with twins will have type 1 diabetes. You would think, if it's an autoimmune function, it's a genetic issue, that all of the twins would, your identical twin would have the disease, and that does not seem to be the case. Whereas type 2, as I mentioned, usually insulin is present, but the person has an insulin resistance, as I'm trying to elucidate here before. It's usually adult onset, but it doesn't have to be. And we're finding out more and more younger adults, 18-year-olds, 17-year-olds, 16-year-olds, sometimes even 15, 14, 13, young adults are getting this type 2 diabetes. And it's sort of as a growing epidemic of weight gain has occurred in the United States, we've seen more and more cases of that. And although we think this is all, diet related, and we'll talk about this, and we think this is related to weight and whatnot, it's still there's a much higher family history of diabetes in type 2. 65% of people with type 2 diabetes will have a first-degree relative with diabetes type 2. And 90% of their identical twins will have diabetes in some reports. So it's a very, very prevalent disease among families. And so how do you diagnose diabetes, and how do you know if you have it? So as I mentioned here, oftentimes it's diagnosed on a routine or random blood draw. But what are some of the other ways you can diagnose it besides a random draw? Anybody have any ideas? Yeah, so these are great symptoms. So if you have thirst, okay. Exactly. If you're going to the bathroom a lot, specifically not only during the day when you're drinking, but also at night when you're not drinking water and you're not consuming beverages and things of that nature. Anything else? Yeah, absolutely. Fatigue is a big one. Yeah, so you can if you start getting real sick, you can start getting shaky and a little, your sensorium or mind gets a little disrupted or foggy. Anybody know what the lab tests and stuff like that you need to do to make the diagnosis? Right, so there's about 4 different ways we can make the diagnosis. One way is the random blood sugar. If you see a random sugar, if your doctor checks it at 2:30 in the afternoon, you're in the office and they see your sugar's over 200, that will make the diagnosis. This is not the best way to make the diagnosis. I mean, everybody who has a sugar, basically almost everybody who has a sugar over 200 will eventually have the diagnosis. But what we found is actually people who have a random blood sugar over 140 or 130, 50% of those people will be diagnosed with diabetes. So random blood sugars aren't always the best way to make the diagnosis. Unfortunately, sometimes it used to be the easiest way, because you don't have to bring anybody back for a fasting test. You don't have to come back for a 2-hour test. But we found a couple different other ways. Another test is a fasting blood sugar of 126 or higher. And the third way is so that means first thing in the morning, you wake up, you don't eat anything or drink anything after midnight, and you come and get your blood drawn. And if it's over 126 or greater, that makes the diagnosis. If you have a glucose tolerance test where we give you a sugary drink, and then 2 hours afterwards, if your sugar's over 200, that makes the diagnosis. And then the final way is a hemoglobin A1C. It's called an HbA1c. And if that's greater than 6.5%, and that makes the diagnosis. And what an A1C is people with diabetes hopefully have a pretty good idea about this, because their doctor will frequently refer to this as a test to see whether they're controlled or not controlled. The A1C tells us basically what your average blood sugar over the last 3 months are ranging between. So an A1C of 6.5% would be about 135, 140, somewhere in there. So 130, 135, somewhere in that range where that's your average blood sugar over the last 3 months. And so we use that a lot of times to help us decide, when you're coming to the office, we don't know what your sugars are doing for 24 hours. You're not checking your sugars 20 times a day. A lot of times you're checking 2, 3, 4 times a day. This gives us an average of all your sugars over 3 months. Anybody have questions about this?
Yes,
Yeah, fire away.
how about if you're taking cholesterol or triglycerides medication, how much does that have effect on the glucose reading?
That's a great question. So some of the, yeah, sure. So the question was, if you're taking a triglyceride or a cholesterol medication, how much will it affect your sugars? And there are some medications like niacin or niaspan that will certainly has the ability to increase your blood sugars. There's some medications actually that decrease your blood sugars of the triglyceride medications. Usually doesn't have a profound effect, but there can be some differences with the medications. In fact, the diabetes, sometimes in improving your diabetes, actually will have a major effect in your triglycerides. If your triglycerides are, over 1,000 or 1,000 or whatnot, 500, 600, 800, 1,000, and your sugars are way high in the 300s, 400s, lowering your sugars to the 100s will actually have a pretty good effect on your triglyceride levels. And so, go ahead. What's normal and so that's a great question. So a normal blood sugar, I'm giving you all these abnormals. What's normal? So, yeah, exactly. So if you have a fasting sugar between 60 and 99, that's actually considered normal, okay? A fasting sugar between 100 and 110, 125 is considered a pre-diabetic. So that's a fasting sugar. A blood glucose 2 hours after you eat, if it's between 140 and 200, that's considered abnormal. Between 140 and 200, it's not considered diabetes, but that's considered abnormal. And a blood sugar under 140 after you eat is considered normal. Pre-diabetes, yes. That when you have pre-diabetes, and we haven't discussed that too much, we'll get into that in a minute or so. When you have pre-diabetes, that gives you an increased risk of developing diabetes over the next 5 years and longer. And so we try to aggressively manage your diet and exercise, and we'll talk about that here in a few seconds, to try and prevent the onset of diabetes. And a pre-diabetes is between 100 and 125 for fasting, yes, and 140 and 199 for 2 hours after a meal. And the last one is it's between 5.7 and 6.4%. For an hemoglobin A1C. Okay. And so why did we pick these numbers over here in terms of why did we pick these this A1C, this blood sugar, and things like that? Simply put, it's where disease occurs. If we look on the side here, this is retinopathy, which is basically diabetes in the eyes. You can see where the fluctuations are over here. Is when there's a fasting blood sugar, here's a 2-hour sugar, and here's your A1C. And you can see, you basically have the same amount of disease from an A1C of 3.4% to an A1C of about 5.7 to 6%. But once you get around 6.6, 6.7 and above, and see in different populations, whether the Pima Indians, some Egyptian population, or North American population, almost all of them, right around 6.5, 6.7, almost all of them spike up, and they cause, you can see the disease starts to occur. Now, that's why we define diabetes in that range, because really, what's the point of managing sugars if they don't do anything for you? If it doesn't cause complications, who really cares if your sugar's 100 or 130 or 190 or 200? If it doesn't cause complications, what's the point of it? As long as we're not getting the ends 30s and 40s and you're not at the high ends 400s or whatnot, it's the complication rates. And that's important when you're taking any medications, no matter what medications you're taking, no matter what, for any disease, is that you want to make sure you're not just managing numbers. You want to make sure the numbers that you're getting to are preventing the reason why you're taking the medication. The reason to take diabetes medication isn't just to lower your A1C, isn't just to lower your blood sugars. The reason to take the medication is to prevent complications. The reasons to take the medication to prevent the subsequent disease, and we'll talk about that here in a second. So we talked about the symptoms. Certainly type 1 diabetics, people who come in, and this happens a lot of times in the younger population, they come in severe fatigue, nausea, vomiting, abdominal pain, confusion. They kind of have excessive weight loss, excessive urination and thirst. I think we hit through all those things. And type 2 diabetes, actually, a lot of times there may be nothing. It's just, you went to your doctors, and I hear this about, 5 or 6 times a week. I went to my doctors, they told me I have diabetes. I didn't know anything about it. Or I was getting a life insurance policy, and they said, I better go see my doctor because they're worried about diabetes. Or, a Department of Transportation physical. I hear those a lot of times. They come in and they say, yeah, by the way, I had no idea about anything, and they checked my sugars and it was 250, and now now I have diabetes. And the same sort of complications, the same sort of symptoms can occur with type 2 that type 1, and that usually just pretends to probably a little sicker when you first get diagnosed. If you have fatigue, if you have weight loss, if you have high urination, high thirst, and things like that. And so the question we should be asking ourselves: how do we prevent diabetes, or in the pre-diabetic stage that we alluded to? How do we prevent that from occurring? That's a great answer. So, yeah. So we hit the two hot button numbers right off the bat: diet and exercise, and leading to weight loss. Right. So the three things are sort of tied together, and diet, exercise. I use the same ones. And how do we know those occur? How do we know that those things help? Do we know that they help? I'll show you some slides here. So a few years ago, we did a nice large study, or I didn't do it, but some people very smart did a nice large study, and they published this article in the New England Journal of Medicine a few years back, and basically this is a diabetes prevention trial. And what we looked here is, we said, let's arrange three different populations. Let's give one population, we're going to tell them to just do your standard diet and exercise therapy, whatever we think is going to work. And then the second population, we're going to actually, and these are all pre-diabetics, people before the onset of diabetes. In the second population, we said, let's give you a diabetes medication, a very good medication like metformin, and see if we can, by giving you a diabetes medication before you have diabetes, let's see if we can prevent that from happening. And the third population, we said, well, we're going to give you an intensive lifestyle regimen. We're going to make you walk 30 minutes 5 times a week. We're going to aggressively manage your diet, and we're going to try and lose about 5 to 10% of your weight over the next several months and whatnot. And this is what we found over the following years. The bottom graph is years. This is the first change in weight. And you can see lifestyle modifications, changing, just walking 30 minutes 5 times a week, as well as trying to lower improve your diet to lower your weight. And these people tended to lose 7% of their weight. So this is not dramatic weight loss. And at 7%, if you take a 200-pound person, that's what? 20, 10, somebody can give me a number here. That's about, 15 pounds. It's not a dramatic weight loss. We're not talking about 50 or 60 pounds here. 15 pounds is a somewhat reasonable goal. And you can see over here, their weight, the people on this line did much better in terms of their weight. And what happened to their physical activity? At the end of the trial, they had better physical activity. What happened to their hemoglobin A1C? This is really important here. The people who on this line right here, their A1C with lifestyle, they tended to do a little bit better for almost all the years until the very, very end than the people who were given actually diabetic medication. The people who had placebo, who didn't get anything, just got placebo pill, they tended to have a higher A1C. And this is, I think, the really important slide. What's the chances that the people got diabetes if they had all three treatments? And the chances with lifestyle modifications, trying to lose weight, trying to improve your diet, meeting with a dietitian, I forgot exactly how often they met with a dietitian, but they met with their doctor 3 times a year, or 3 to 4 times a year. You can see the incidence of diabetes was almost cut in half compared to if you did nothing. So that sort of became the impetus to really drive home the fact that just walking, exercising 30 minutes 5 times a week, improving your diet to try and lose weight, 5 to 7 pounds. And there's a lot of people who didn't lose weight. Not everybody lost 7%. But cumulatively, they had a lower incidence of diabetes. And so that's, I think, an important slide to sort of force home that even just taking medication, although it seems the simplest thing to do, wasn't always the best thing to do, even if it was a diabetes medication. So, this is diet and exercise, vitally important in the treatment of prevention of diabetes, as I mentioned. Lower weight, 5 to 10% of your current weight, and approximately 150 minutes a week or 30 minutes 5 times a week. And it's very hard when you haven't been doing anything, and there's a lot of different forces in your life trying to pull you in different areas to try and say, okay, I'm gonna do 30 minutes 5 times a week. But all I can say is, a matter in motion tends to stay in motion, and so a matter at rest tends to stay at rest. And so, starting out in small increments, 5-10 minutes around dinner time, or 15 minutes before in the morning before breakfast, has powerful changes in how your psychology works in terms of improving your exercise regimen. And so you can't talk about type 2 diabetes, especially, without relating it to weight. And it's very closely related. And over the last 20 years, as the weight of American population has gone up, so has the diabetes. And almost all talks that you'll ever hear about weight and diabetes, they have to show you this next few slides here. And this is on the left. Hang on before I let it go. On the left is the obesity and increased weight trends. On the right is your diabetes trends. And you can sort of see, as it gets darker, there's more people who get diabetes. And we started having to invent newer colors and whatnot to make the diagnosis. And so, as you see here on the left, as people start gaining weight on the left, excuse me, on my left, it's over here on the it's your left too, on the right of the thing. The left over here, as the weight tends to go up, I'm gonna go back to 2000. As the weight tends to go up, the diabetes trails right after it. And you can sort of pretty powerful slides in terms of what's been going on. And you can sort of see and this is from the CDC website. You can sort of see what's been going on over these last 20 plus, 18 plus years. As I mentioned, we had to invent new colors. In the initial, we didn't even have data in some states about how many people were overweight. And as you can see, anyways, it's gotten worse as the years have gone by. And so, as I said before, what are the reasons we care about diabetes? And anybody have any answers? Why do we care about it? What are those things that we care about?
Loss of limb.
Yeah, so exactly, loss of limb. And the way we characterize that is what we call peripheral, meaning in the periphery, vascular disease, or neuropathy, because a lot of times people can't feel the pains and whatnot when they get ulcers and infections in their feet. They don't feel the pain, and the ulcers and infections tend to linger a little bit longer. Anything else? Eyesight, excellent. So retinopathy, as we talked before, you can get some bleeding in the back of your eyes and subsequently cause some tearing in your retina and scarring of your retina, and eventually cause problems with your eyesight. Absolutely. So people with diabetes, they're at an increased risk for cardiovascular disease. And, we treat people with diabetes, okay? We treat them as if they've already had a heart attack, meaning any of their risk modifications, their cholesterol, their blood pressure, anything like that, we basically put them in the same class of risk modification as if they've already had one heart attack, even if they have had none. And so, yeah, it's a strong cardiovascular risk factor. I'll just, because it causes complications. So cardiovascular disease. And then the other thing is cerebral vascular disease, strokes and mini strokes and TIAs and whatnot. And then nephropathy, this is the last one we forgot about, kidney disease leading to dialysis and whatnot. And retinopathy, eye disease and blindness, and neuropathy, nerve damage and amputations, as you mentioned. And so how do we know that improving diabetes improves things? Well, a few years back, and so I just want to make it clear that this over here is what we call large vessel diseases or macrovascular complications. And on the bottom is small vessel diseases or microvascular complications. And the reason why we want to treat it is we want to prevent these things from happening. And I show you two graphs here. One, and basically the dotted line shows if we intensively try and control your sugars right from the bat, right from when you're diagnosed with diabetes, at the end of the thing, all this doesn't look that dramatic. It is a significant decrease in the amount of microvascular complications, the things with eyes, kidneys, and eyes, kidneys, and nerve damage. We have a significant reduction, as you can see on this side, compared to this other side. And there's a tendency also, 5 years after the reduction, there's a tendency to have fewer heart problems and whatnot after you intensively control. So when you see your doctor, they may say, you know what, your sugars are really out of control. We really want to get this under control as quickly and as safely as possible. They may say, you know what, we should maybe start 2 or 3 medications or 2 medications right off the bat. Or we may want to start insulin right off the bat because we want to get this done as soon as possible. And the reason why they say that is because of slides like this, because the quicker we can get it under control, the sooner we can get it under control, the better it is for you long term. And so I just wanted to show you some pictures of the eyes, just to give you an idea of why we keep looking at. I mean, everybody has an idea of what's going on in the feet and the heart and things like that. Just look at the eyes. This is a normal retina that we're looking at. And over here, we're looking at, from a couple different websites, we're looking at what we call non-proliferative retinopathy. We're looking at these spots over here, these red spots on the side over here, and these yellow spots. And these are small spots that have what we call dot blot hemorrhages, and their tendency, they're a sign that that your diabetes, that there's already diabetes in the eyes. And what we're trying to prevent is this, where you get more new vessels, blood vessels occurring in your eyes. And these new blood vessels, while it sounds nice, you're getting more blood going through your eye, these vessels are very flimsy and weak, and they tend to tear and break a little bit easier. And so you tend to get a little more scarring or bleeding in the back of the eye, and then you have things that happen like this. And as a result, that causes problems. And then the other slide I want to show you is just what we're talking about neuropathy and ulcers. These are some of the pressure points at the balls of your feet and at the heels, and you can sometimes see some small, as you keep rubbing against your tight shoes and ill-fitting shoes and whatnot, these are the sites that might get a little disrupted, and sometimes you can see an ulcer that looks not great. And so how do we get to an A1C of less than 7%? Why do we say less than 7%? The real reason, we said you diagnose at 6.5%, and we're trying to go less than 7%. What's the difference? Well, it's pretty much where the risk of those complications that we mentioned, the heart disease, the strokes, the kidney, the eyes, and the nerves, the risk of those complications starts to flatten out. After you get from 7 to 6.5%, there isn't a great reduction in risk, and 6.5 to 6%, there isn't any significant decrease in complications. And so, this is by American Diabetes Association to get the recommendation to get the A1C to less than 7%. And that comes out to an average blood sugar of less than 154. And how do we get there? We treat the insulin resistance, and we treat the insulin deficiency. And how do we treat the insulin resistance? The best way to do it, as I said before, is diet and exercise. I'll say it again, and if you ever come and see one of our partners in the practice or myself, well, I'm sure this will be reinforced, at least 100 times. And diet and exercise is one of the best ways to do it. Now, sometimes it's tough to do that stuff, and you try to amend treatment for your physical activity, but anything is better than nothing. And we know extreme weight loss, specific gastric bypass, that has some effect on improving diabetes. And then again, this is another study from the New England Journal of Medicine that showed 2 to 10 years out after having a gastric bypass surgery, people on the dark blue bar didn't get the bypass, and people on the dark bar, on the light bar did get the bypass surgery. And after having this surgery on the left here, you can see that extreme weight loss did cause diabetes. Now, this is not me saying going out and telling everybody to get a gastric bypass, just that we know that weight loss will make a change. Now, the caveat here is that there are other factors that are involved with gastric bypass besides just the weight loss. There's different gut hormones that are being affected. But I think it's pretty good, it's fair evidence that suggests that weight loss will improve your diabetes. Yeah, go ahead. On the right-hand side, hypertension, hyperuricemia. Hyperuricemia is for things like gout and things like that. Sometimes uric acid can be a predictor of cardiovascular disease, and so that's what they're looking at. Yeah. So what are some of the medications that improve insulin or insulin resistance? The two major medications are metformin and Actos. There's a lot of controversy about Avandia and what its role in the market. I don't know if anybody's read or heard anything on the papers recently. It has not been withdrawn from the market. There's concerns about whether it caused an increased amount of cardiovascular disease and whatnot, and the FDA is sort of deciding about that. But essentially, these two are the best, the big players in terms of improving the insulin resistance in the blood. Yeah.
So the metformin, if you only take one per day, does it matter when in that 24-hour period?
Essentially, no. I think you can take it probably, if you're taking the extended release metformin, you can probably take it pretty much at any time of the day. Sometimes you get a little bit fewer side effects if you take it half an hour or 45 minutes after eating a meal, as opposed to right with your meals if you're having a lot of gastric indigestion and side effects and nausea, vomiting. But if you're taking the extended release, it probably. No, I mean, usually we recommend take it, if you're taking the regular metformin, take it with your meal in the morning. And then sometimes if it's a regular one, you have to take it, it's a recommended to take it twice a day. So you take it before breakfast or around dinner time. And then there's the insulin deficiency medications, the glyburide, glipizide, glimepiride, all these force, and then I didn't add the other ones, but there's another class of medications that like Starlix or Prandin that all force the pancreas or induce the pancreas to make as much insulin as it can. And then there's a newer line of medications out there called Byetta, Victoza, Januvia, or Onglyza, and they all work to help you make more insulin when you eat, try and suppress your appetite a little bit. They work with different gut hormones that are really newer medications out on the market, which when I say newer, the first and the third one have been out. I don't want to be misquoted, but I think about 4 or 5 years now. The second and the fourth are fairly new to the market. And then there's insulin injections. Sometimes, the average time span from somebody who gets diagnosed with diabetes, the average, this doesn't mean everybody, but the average is about 8 to 12 years from the time you get diagnosed to the time that insulin is started. And so, there's a lot of apprehension about starting insulin. If you're able to check your finger sticks, it's probably less painful than checking your own blood through your finger sticks. There's fewer nerve endings in your subcutaneous fat in your abdomen, so therefore it tends to be a little bit less painful. It's a safe way to reduce your blood sugars, especially if you have kidney disease or liver disease. It may be a little bit safer than taking some of the medications out there. And it has fewer extra organ side effects, meaning some of these other medications we worry about taking with heart failure, or we worry about taking with kidney disease, or we worry about taking with liver disease. The insulin tends not to have extra organ side effects as far as we know so far. So in wrap up, before I answer any questions, it's of great concern. There's increasing prevalence and incidence, and there are different ways to treat your high blood sugars, and it certainly needs attention when you get diagnosed with it because of those complications. And in summary, this is my son eating a nice big ice cream cone, and he says, "Please don't control my sugars too tightly." Thanks. Great question. Yes and no. It's important to eat. It's important to eat your if you can, your three meals a day, with some small snacks in between. The reason why it's not as important as long as you're not binging and eating. The problem with some people, with weight, especially with weight loss and things like that, is that you eat at breakfast or eat a small snack at breakfast, and then you go 4 hours, 6 hours, 8 hours, and you don't eat anything. And then that supper meal at 4:30 tends to become a very, very big meal. So in terms of diabetes, we usually recommend, 3 meals and with small snacks in between. It's especially important if you if you're taking certain types of insulins and certain types of medications. I put up here before, I don't know if I just pull it up for you here. Especially if you're taking these medications, glyburide, glipizide, glimepiride, Starlix, or Prandin, if you take those medications, you really need to eat consistently through the day, because if you're not taking your medication, if you're not eating when you're taking these medications, and about 4 to 6, right when you eat and 4 to 6 hours after you eat, you're going to get low. And some insulin's the same sort of thing. There's some different insulin preparations where they have a combination of long-acting and short-acting insulin inside it. And if you don't eat 4 hours after you eat that meal, after you take that injection, you can get low. It's not all of them, but for some of them they do. So to answer your question, yes and no. Do you have to eat at 8, 1, and 6 every day? No, you don't. I don't think that, I don't have to be that strict and that regimented. But I think eating a general breakfast, general lunchtime, and general supper time, I think is a good idea. Right. So I have to look this up again, but it's FDA approved. I'm certain of for diabetes. I'm not quite certain if it's FDA approved for pre-diabetes. It's essentially a diabetic drug. We've used it in people to prevent diabetes, in concert with diet and exercise. Metformin's being used for a lot of different applications besides just diabetes. But yeah, it's a diabetic drug. We use it also for pre-diabetes, but it is a diabetes drug. Yeah, I'm sorry. One more thing. It also helps treat insulin resistance. That That's one of the nice benefits of that. It helps treat insulin resistance. It's one of the medications out there that's a weight loser, meaning you might lose between 3 to 5 kilograms of weight on the medication on average. So that's other benefits of it. And it has long-term cardiovascular improvement with it. Yeah. Yeah, so that's another great question. So we used to, kind of. We've unfortunately we've confused everybody with this terminology. You know, we said juvenile diabetes, adult onset diabetes. We say non-insulin dependent diabetes, then insulin dependent diabetes, and then we said glucose intolerance, or we say impaired glucose, impaired fasting glucose. Glucose intolerance is essentially diabetes. I think sometimes we used to refer to that as a pre-diabetic sort of state, and so glucose intolerance now sort of means, or impaired glucose tolerance is now considered pre-diabetes. But it's essentially the same thing. I mean, what we're trying to convey with that is that if you're eating a meal, after you eat the meal, your metabolism is intolerant basically of the glucose, and your sugars tend to rise after that. So they're similar, but I think what we're trying to say when we say glucose intolerance is that you have pre-diabetes. That's a great question. The metabolic syndrome is as you mentioned, a syndrome where we pull 3 to 4 or 5 different categories together, where it's your waist, your blood pressure, your sugar levels, your triglyceride levels, your HDL levels. We try and pull them together and say, is this causing a syndrome where you're at risk for cardiovascular disease and whatnot? So if you get diagnosed with diabetes, that sort of trumps metabolic syndrome. That becomes your diabetic and your cardio. The reason why we say metabolic syndrome is to classify try and give you a better classification of your cardiovascular risk. And so once you get diabetes, your cardiovascular risk goes to one of the highest points. In terms of weight loss, certainly it's hard. I mean, it's hard to lose. It's not easy. If it were easy, everybody would do it, right? I mean, it's as simple as that. But I mean, I don't know that and I'd have to look at studies, and you certainly can ask me again whether it's harder to lose weight if you're diabetic or if you're metabolic, if you have a diagnosis of metabolic syndrome. I'm not quite certain of that, but did I answer your question at all? Or?
Yeah, I just.
Well, the weight loss and when you first get diagnosed with diabetes is really right when you're diagnosed with diabetes is usually because you have high blood sugars, and high blood sugars cause weight loss. In terms of metabolic syndrome, you're not having high blood sugars, the blood sugars high enough to cause diabetes, so you might not have that weight loss associated with that. I don't know if that's what your physician was referring to. Carbohydrates and fatty meals tend to raise it, but it's the carbohydrates and whatnot that tend to push the sugars up a little bit higher. People tell me, I eat a pizza, and my sugars went to 400, or I ate a piece of cake and my sugars really jumped up on me. So it's the fat plus the high fatty diets plus the fried foods and whatnot plus the carbohydrates. Yeah, the question was, when should a referral to an endocrinologist be made in the course of the treatment of diabetes? And I don't have a perfect answer for that. I'm sure different societies have different answers for that. I would say that if you're not getting adequate treatment, i.e. you're not getting adequate improvement in your hemoglobin A1C, in your metabolic risk factors, your cholesterol, your blood pressure, your diabetes, all three which are very closely related in terms of your cardiovascular risk, after a certain period of time. What that period of time is, I don't know. I mean, a lot of times primary care providers feel what I've seen a lot of times, primary care providers feel very confident in managing oral medications and giving 1, 2, 3 medications, and a lot of them feel very confident giving some insulin. Some feel very confident all the way through. Depends on their level of confidence and their training. What I found a lot of times after they start insulin, people have started insulin, they don't get the results that they want. We tend to come in involved, but I've seen every side of the spectrum. I've seen people come in with A1Cs that are 6.6%, and I've seen people come in with A1Cs of greater than 14%. So I don't think there's any set point other than as long as whomever's taking care of you feels confident with what their treatment plan is and has the resources to help you out, not just with diabetes, as I said. I mean, Diabetes is we're trying to prevent cardiovascular disease. We're trying to prevent the complications, the microvascular complications. And so as long as there's resources in trying to help you with your diet, your nutrition, your exercise, and everything else, I mean, we don't necessarily have to come involved at all. But that's sort of it. Type 1 diabetics, I think I would sort of err on having us get involved a lot earlier than later. A lot earlier than later.
But I think the endocrinologist blood test, I mean, there's about 20 things that they check.
That's right.
Albumin and protein and,
Yeah, so we check protein in the urine, exactly.
a rundown of your heart, your lung, your liver, your this and that.
Right.
So I try not to do that.
Well, yeah. And there's lots, and I'm not here to disparage anybody, any other specialty. I mean, there's lots of primary. I mean, I've had patients come to my office and they have all their labs checked before they came to see me, and there's nothing for me to do other than start changing, modifying their treatment regimen, in different ways. I thought I saw a hand back there. No. Okay. Well, anyway, so if you have any questions, I left my number around there. Certainly give us a buzz. I'd be happy to discuss it with you, and thanks for having me here.